Welcome everyone to today's session of our survivorship series. Today's topic is Sarcoma Survivorship 101 and Key Issues led by Dr. David Schulman. This program is hosted by the Blum Resource Center. Over at the Blum, we are grateful to the survivorship team for this continued partnership. The recording of the session will be posted on our Blum YouTube playlist and our Blum Digital Resource Center, as well as the survivorship website. For those of you watching live, if you have any questions related to today's program, please feel free to utilize the chat feature throughout the session. At the end of the session, your questions in the chat will be used to moderate a Q&A. If you have any other questions or would like more information about resources and programs offered through the Blum, please visit our website at www.dana-barber.org/resource center, or you can reach out to us by email. I will pass it over to you. Thank you, David.
Thank you, Becca. I'm just thrilled to join today and share a little bit of information about survivorship for patients diagnosed with sarcomas. Again, I'm David Schulman. I'm a by training pediatric oncologist. I work in the Dana-Farber Cancer Institute Sarcoma Center, in the Dana-Farber Boston Children's Cancer and Blood Disorders Center's Pediatric Oncology Program, and do clinical research as well. Let's see if I can advance here. I have no relevant disclosures, but I will again remind the group that by training I'm a pediatric oncologist, so I have a little bit more of a focus on folks diagnosed with sarcomas in their younger years. My primary clinic goes up to age 40, but I'll try and hit on themes that are relevant to folks of all ages. By way of overview, I wanted to handle today's session sort of as if you were going through a survivorship type visit. I'll start with some background on sarcoma and survivorship in general, just so we're all sort of talking the same language, and then go through really kind of a case study. It's a fictional case study, but of a patient who is sort of going through a survivorship visit and focusing on surveillance for their cancer, looking at physical late effects and psychosocial challenges that come up during and after treatment, and then to finish sort of thinking about healthy lifestyle during survivorship. So by way of background, sarcomas, it's just important to know from the outset, are a rare group of diseases, but carry a large burden of long-term health issues. And so, you know, right off the bat, I think very important that we're thinking about survivorship together. Sarcomas comprise about 1% of all cancers, but make up about 8% of cancers affecting adolescents and young adults. Those are folks who are diagnosed with cancer between the ages of 15 and 40. There are more than 100 types of sarcomas and require really a range of treatments, which is an important theme of today's session. And those treatments, unfortunately, often come with what I think is really a disproportionately high burden of long-term health complications. And again, why survivorship is so important for this group. The variations in sarcoma subtypes and the required treatments really result in varied risk for long-term health issues. So sarcomas can range from being benign with no potential to spread, and on the very other end of the spectrum, very highly aggressive tumors that have already spread at diagnosis and require very, very aggressive treatments. They can really present at any age, which separates them from many other disease groups, and they can arise anywhere in the body, which also separates them from other disease groups. For example, in comparison to prostate cancer or breast cancer that really primarily arise in those anatomic locations, sarcomas can unfortunately pop up anywhere. The treatment for sarcomas is very much tailored to the primary location, the histological subtype, and the stage. Surgery is required for most patients. Radiation is often required depending on the particular situation. And then some patients require very intensive chemotherapy or long-term use of newer targeted therapies, all of which can sort of come with their own list of long-term problems. Given the variations in types of sarcomas, the treatments required, survivorship care really must be individualized for patients with sarcomas. So by way of overview, cancer survivorship really refers to the health and well-being of a person with cancer from diagnosis onward. And this includes the physical, mental, emotional, social, and financial effects of cancer and the treatment that comes with cancer. Um, Survivorship really begins at the time of diagnosis, and survivorship care takes place in a range of settings, including the oncology clinic, the survivorship clinic, the primary care clinic, and requires really good care coordination. I think one of the reasons why I was so excited about this talk is that the good news here is that although there's a long list of problems that come with these treatments, we have many resources and really a growing body of resources. So on the right, there's a lot of different ways to break down survivorship care, but I think roughly you can group this down into monitoring and intervening on physical and psychological effects of cancer and treatment, screening for subsequent cancers, surveillance for the current cancer to make sure that does not come back, and if it does, we identify it ideally early, and then routine healthcare, and how do we integrate all of this with routine healthcare. As I mentioned, by training, I'm a pediatric oncologist, so I spend a fair amount of time thinking about young adults with sarcomas. And this group we really know is at high risk of cancer and treatment-related long-term health issues. Adolescents and young adults diagnosed with sarcomas between the ages of 15 and 39 have unique health concerns. Sarcomas presenting in this age range often require aggressive treatments. Survivors, when they're surveyed, report relatively high levels of psychosocial distress compared to older and younger patients. And the needs of this population require special consideration in survivorship. Some of those considerations may include sexual health support, fertility counseling, and returning to school and work when cancer comes at a very disruptive time of life. We have a really great young adult program here at Dana-Farber that sort of spans all of the young adult disease groups, including sarcoma, but also hematologic malignancies, germ cell tumors, and so on and so forth. We're in the process of launching an adolescent and young adult sarcoma program that's really dedicated to this particular group of patients. So as we sort of get into what your we'll say first survivorship visit might look like, if you were somebody who'd had treatment or is currently getting treatment for a sarcoma, and again, we really say that survivorship begins with diagnosis, and I think that's really true and important for patients with sarcomas. The first official survivorship visit typically takes place after completing planned treatment, and usually begins in the oncology clinic and then over time transitions to a survivorship clinic and eventually a primary care clinic. In those visits, the things that we think about and the things we'll focus on today are what were the exposures and risk factors included with treatment or that came with the particular type of tumor. And so some of the things that are really important are cumulative doses of chemotherapy. What was the radiation exposure, or what was the dose of radiation used, and where was it given in the body? And then what type of surgery was performed for the sarcoma? You'll review the current treatment or surveillance schedule. Some patients may be on a maintenance therapy, or they may be done with treatment and just getting periodic scans. The physical examination and ancillary tests are really important, and those might include things like a heart examination, a skin examination, lung examination, and then an echocardiogram to look at the heart in great detail. And then based on all of that data, counseling and recommendations for, again, doing all that we can to support healthy physical and psychosocial well-being during and after treatment. So we'll jump into our case study. This is really a fictional patient, but I think highlights some of the real issues that patients deal with during and after treatment. So This is a 28-year-old man with a history of localized osteosarcoma of the right distal femur. That's the sort of area just above the knee. And this patient had standard treatment with 3 chemotherapy drugs, methotrexate, doxorubicin, and cisplatin. The patient had surgery to remove the tumor, and then had a piece of artificial bone that was put in, and recently completed treatment and is now in the process of doing surveillance scans. We do something called a review of systems, which is just our funny way of saying, kind of asking head to toe, how is everything feeling? How are your eyes and ears doing? How is your mouth doing? Any dental issues, any heart and lung issues, and so on and so forth. And what we learned is that this patient's having issues with decreased mobility of that right leg, is having some ringing in the ears after treatment, and is having some issues sleeping. These are all, unfortunately, relatively common problems that patients face after treatment for osteosarcoma. We dive a little bit into how things are going in life in general, and whether or not life in general is getting sort of back to normal. And this patient reports an interest in returning to work, where they were previously working in sales. That is often a challenge for patients. They're currently living with their partner, and they're also starting to think now about starting a family in the future. On examination, their weight is below what it was before they were diagnosed. They've had some muscle loss throughout therapy, and they have a bit of a limp, or what we might call an antalgic gait. We would put together an assessment, and a very sort of brief and simplified assessment for this patient would be that they're a 28-year-old, they have a history of osteosarcoma, they're currently in radiographic admission, or their scans look good, continuing with surveillance, and are recovering well from therapy, but have some emerging late effects from treatment, like the ringing in the ears and the pain in the knee. And so the first part of our plan for this patient is surveillance. And for this particular patient, the care team has come up with a plan to do scans and physical examinations every 3 months for the first 2 years, then space those out to every 4 months for 2 years, and then every 6 months for 1 year, and then yearly thereafter. We come up with these particular surveillance plans based on guidelines from places like the National Comprehensive Cancer Network, and that's where this very complicated guideline comes from. We also often rely on guidelines from the Children's Oncology Group, which has established surveillance schedules for certain diseases like osteosarcoma and Ewing sarcoma that are also seen frequently in teenagers. And I don't want to belabor any of the details of this very complicated guideline, except to say we have guidelines both for what we should do during treatment with chemo, with surgeries, with radiation, but also how we should follow patients after they finish treatment with scans and examinations. In terms of thinking about sort of what are the principles of how we do surveillance and why do we do things the way we do, I want to note that the risk of recurrence for most sarcomas is really highest in the early years following treatment and decreases over time. And as a result, we've typically come up with scan schedules in which the frequency decreases over time. On the right here is what we call an event-free survival curve, in which we look at patients from the time they are diagnosed until going out 5, 6 years, and so on and so forth. And what we know now, this particular curve is for Ewing sarcoma, but they look similar for many of the types of sarcomas we treat, is that usually when we see the sarcomas come back, that's most commonly in the year or two after we finish treatment, which is right in here in the 12 to 36 month mark. And then as we get further and further out, it's less and less likely that we see it's less and less likely that we see the tumor return, and we tend to space out our scans. I'll point out, and this will be, I think, painfully obvious to anybody listening who's going through this, that returning to clinic for scans and examinations can really be tough and cause significant anxiety. I think that's always an important thing to bring up with your team, and often not something that we spend a lot of time talking about in clinic. And the last thing I'll say is that although we do have these great guidelines, um, it is important that we think about individualizing the type of scans we're doing in our schedule for scans to the individual patient and situation. So continuing on with our case study, we've now sort of gotten past our surveillance plan. We know that we're going to look more frequently early and then space those scans out later. And we start to get into what we call late effects or long-term health effects of cancer in cancer treatment. And so for this patient, the first thing we think about is risk of doxorubicin-related cardiotoxicity. Um, Doxorubicin is an important medication given for a lot of different sarcomas, including osteosarcoma. And for this patient, following guidelines from the Children's Oncology Group, we would get echoes every other year to check their heart function. There's a couple other items listed here, and we'll jump to those in just a moment. But I'll point out that for survivors of bone sarcomas, particularly Ewing sarcoma and osteosarcoma, risk of having musculoskeletal and heart complications are two of the biggest issues that we think about in survivorship care. And so I promise I won't have too many more graphs after this one in the presentation, but I'll point out here, this is a study that comes from what's called the Childhood Cancer Survivor Study, and where we get a lot of our data on risk of late complications for patients who've had bone sarcomas. And just to say that if you start at about 5 years after diagnosis and follow out to 30 and 35 years later, the incidence or the percent of people who've had a serious musculoskeletal or cardiac issue is quite high. And so those are the two things that I wanted to start with. How do we manage heart issues after treatment, and how do we manage pain and musculoskeletal related issues after treatment? So risk factors for cardiac complications. Doxorubicin is one of the biggest ones for patients who have had treatment for sarcomas. Exposure to doxorubicin is associated with cardiac muscle dysfunction in both children and adults, and risks increase with higher cumulative doses. This patient had standard treatment for osteosarcoma and received 450 milligrams per meter square of doxorubicin, which is a high dose. The slide that I showed on the previous study, by virtue of the fact that they followed those patients for 35 years, is a very old study. That means many of those patients were treated 40 years ago. We've gotten better at giving a lot of the treatments that we give for sarcomas over the years. And so patients now typically receive dexrazoxane for cardiac protection. It's a medication that really reduces those late risks of heart issues. But still important that we screen for these things after treatment. The other important thing that we often think about is whether or not there has been radiation that involved the heart muscle for treatment of the sarcoma, as that can really contribute to late cardiac toxicity, both in terms of muscle dysfunction and coronary artery disease and valve disease. The Children's Oncology Group long-term follow-up guidelines, which is something that's periodically published by the Children's Oncology Group, provides monitoring guidelines for late cardiac issues. As you can probably guess for the name, these are really tailored towards younger patients, but especially for folks in their 20s and 30s, I find these provide helpful guidance. And then there's a number of other sources that can provide additional guidelines for older patients to think about what's the appropriate cardiac monitoring after treatment. The last thing I'll touch on here in terms of maintaining your heart health is that there's really now emerging data that not only can we prevent some of this cardiac dysfunction, but some of it may even be reversible when you intervene early. Referral to cardiac oncology or cardio-oncology is really important if there's evidence for early heart dysfunction. And they'll often start with an ACE inhibitor or a beta blocker to manage initial dysfunction, watch very closely with serial echocardiograms or other imaging studies, and ensure that there's no further decrease in heart function or hopefully even it gets a bit better. There's another great video on our survivorship website discussing in a lot more detail what goes on in cardio-oncology clinic, and I encourage folks to check that out if that's an area of interest. So jumping back to our patient, the next thing on their late effects list was pain related to their femoral allograft or their primary surgery. And our plan here was for an initial referral to physical medicine and rehabilitation. Um, Cancer and treatment-related pain and functional loss are really common in sarcoma patients. Our patient had an aggressive surgical resection with replacement of diseased bone by an artificial bone. This is a relatively common surgery for a patient with a bone sarcoma. And in particular, if you look again at childhood cancers, these are patients who've been followed for a very long time. Osteosarcoma and Ewing sarcoma really have the highest rate of late major surgeries of any of the childhood cancers. I think this is also very likely true for young adults who are treated for these diagnoses. Rehabilitation aims to evaluate and treat these functional loss and pain disorders with the goal of restoring function and decreasing pain. In addition to the fact that some patients may require additional surgeries and later in life, there's a lot we can do to sort of mitigate those functional issues and pain issues. There's also some specific impairments that we see in patients who are treated for sarcomas that often have specific referral pathways and specific clinics to deal with these issues. So I've just touched on functional impairments, but some patients may have lymphedema depending on their surgery, and we now have specific lymphedema clinics. Neuropathy is an issue for some patients who've received certain types of chemotherapy. Radiation fibrosis may be an issue for some patients who've had radiation that involves muscle or other soft tissues. Myopathy can occur depending on the treatment, or spinal cord injury if the tumor was involving the spinal cord. And then the last two issues that came up on our patients' review of systems and sort of specific late effects to address at that early survivorship visit included cisplatin-related tinnitus, and this is the ringing in the ears. This is a common problem with cisplatin, which is used for all patients who are treated for osteosarcoma. For this, we're going to do a hearing assessment referral, but also treat other associated issues, including the insomnia that the patient referred to, and depression, which comes out through the course of the visit. For the insomnia, we're going to do a referral to our sleep medicine clinic. At the moment, we happen to have a sleep intervention study, which we'll refer the patient to as well. This, I think, sort of brings us to a really important issue in survivorship, and another thing that we sometimes don't get the chance to spend a lot of time talking about in clinic, particularly oncology clinic, where we have limited time. And that is that psychosocial distress and physical symptoms may be overlapping. Physical symptoms such as tinnitus and insomnia may be mutually reinforcing with depression and anxiety that are unfortunately common after cancer diagnosis, both during and after treatment. Surveys, particularly of adolescents and young adult cancer survivors, not just in sarcoma, but across the board, report poor health-related quality of life and mental health relative to their peers. Numerous studies have demonstrated elevated levels of mental illness and emotional distress in AYAs diagnosed with cancers. Surveillance for these issues is really an important part of the survivorship visit. And there's been good studies recently to also show that mental health surveillance demonstrated an increased risk in adolescents and young adults, but was a relatively low-cost intervention that really had a high benefit to this patient population from referral to mental health services. And so there's a number of specific issues that can come up related to cancer diagnosis, including cancer-related distress and fear of recurrence, depression, suicidal ideation, anxiety, and post-traumatic stress disorder. And we have good resources for these things, but one of the challenges is figuring out how to get to the right resources. Here, it's really important to work with your care team to identify the right resources within the cancer center and within the community. General mental health care after treatment often needs to be pursued through the community. In places like Dana-Farber, we have really great resources for patients while they're on treatment. But as the survivorship population has really grown and needs often evolve after treatment, often patients really need to seek resources through the community where they can be cared for by providers who have more bandwidth to handle this very large population of patients. However, we have numerous cancer-specific resources at Dana-Farber, specifically sleep medicine that really deals with cancer-related sleep disturbances. We have a sexual health center for patients who are cancer survivors, and then Center for Integrative and Alternative Therapies, as well as social work, all of which are really tailored towards patients who are currently getting cancer treatment or who've previously gone through cancer treatment. All right, returning to our case, the next issue that came up in our social history was that this patient noted they are now interested in starting a family. And risk of infertility is an important thing that should be touched on when a patient finishes treatment and is starting their directed survivorship care, but is also very important to be discussed prior to treatment start. And this is one of those things that is a very clear reason why survivorship care needs to begin at the time of diagnosis. All modalities of sarcoma treatment have the potential to impact fertility. And so, for example, a surgery that involves the reproductive organs, if the tumor has originated there, has the potential to impact future fertility. If the reproductive organs are within the radiation field, that could impact fertility. And then multiple different types of chemotherapy have the potential to impact future fertility. And these things really need to be thought out at the time the treatment plan is being formulated after diagnosis. Many patients with sarcomas, fortunately, will not have fertility issues. So there are patients who have a small localized sarcoma of the thigh that just requires a surgery and no radiation, no chemotherapy, and that patient is unlikely to have any future fertility issues. When we survey patients, though, down here at our last point, what we found is that most young cancer survivors report that fertility was not discussed at the time of diagnosis and often not discussed at the end of therapy. And so there's good evidence to say that we need to be doing a better job of this. I think as patients and families have become more and more well educated about these issues, I'm often hearing about them right off the bat when a patient's diagnosed, and I think can be a really great way for patients and families to kind of empower themselves to really help work on this from the start. For actually addressing these fertility issues, there's multiple approaches to oncofertility and fertility preservation prior to treatment. The sort of nitty-gritty of how we do oncofertility and the evidence behind different approaches is beyond the scope of this morning's session. But just to list some of the potential options that we have for patients who are having radiation or surgery that could impact the reproductive organs, there's ways of doing radiation shielding or actually moving the ovaries out of the radiation field that can be really important for fertility sparing. Cryopreservation of sperm or sperm banking in men is the primary means of fertility preservation for men. And for our particular case study, this particular patient would have undergone sperm banking, hopefully prior to the start of treatment. Cryopreservation of embryos and oocytes is also a possibility in women. but sometimes may be very difficult, particularly in high-grade sarcomas, as the amount of time it takes to do, for example, an IVF cycle and collection would not be feasible in a patient who really needs to start treatment. We've increasingly learned that cryopreservation of ovarian tissue with collection during an outpatient laparoscopic procedure is feasible, and that this tissue actually in the future can be reimplanted and lead to viable pregnancies, but requires a lot of care coordination and thought prior to starting treatment. I hope in the coming years this is a possibility that becomes more and more available to young women who are starting treatment for sarcomas. There's multiple different post-treatment approaches to oncofertility assessment. I think there's a couple important points here as well. So first of all, fertility may be transiently impaired following treatment and then actually improve over time. Women can have an AMH level checked to assess ovarian reserve, and men can have a semen analysis as well as testing of hormonal levels, including FSH, LH, and testosterone levels. For this particular patient, they would be at quite high risk of infertility after treatment, given their chemotherapy exposure. But for men who are immediately post-chemotherapy, it's certainly reasonable to have a semen analysis, but to know that if it doesn't show viable sperm, that it should be repeated periodically in the years following treatment, and may actually improve as you get further out from treatment. All right, moving on to the next phase of our patient's treatment plan, we come to screening for second malignancies or second cancers and cancer genetics. And for this, at this time, our plan for the patient is to refer them to cancer genetics. So we'll get into why that's important. So some patients treated for sarcomas may be at risk for developing second cancers later in life. There are going to be some patients where this is really not an issue. Again, for a patient who has a sarcoma in their thigh that requires only surgery, is not related to any kind of cancer predisposition syndrome, they're really very unlikely to be at any increased risk of having second cancers later in life. But what we know is that for many patients with sarcomas, there are underlying factors that can contribute to risk for developing a second cancer. Higher radiation is one of those things, and then treatment with certain kinds of chemotherapy agents all carry a risk of having a second cancer later in life caused by the treatment. The second thing that's important to consider are underlying genetic factors. There's a population of patients with sarcomas who have developed a sarcoma, at least in part, because they have an inherited predisposition for developing a sarcoma. I think it's important to keep in mind that that risk changes over time. And so there are some risks that are highest early following treatment. And so some of the chemotherapies we use can predispose somebody to developing an acute leukemia after treatment. This is quite a low risk, but it is a risk, and that's highest in the sort of 2 to 5 years after treatment and then goes down. Conversely, radiation can cause second cancers, and that risk really begins at about 5 to 10 years after treatment and goes up over time. Cumulatively, these risks are quite low, and they're very low compared to the risks of not using these treatments for the primary cancer. But unfortunately, there's something that we have to keep in mind during survivorship visits. We have ways for screening for second cancers, and the particular treatment exposures really impact how we do those screenings. There are cooperative groups, such as the Children's Oncology Group, that provide guidelines for recommended screening. These are not just relevant to pediatric patients, but again, also really have implications for young adults who are exposed to chemotherapy and radiation. And then we have guidelines for older patients as well. Just as an example, for females who have a history of chest radiation for their sarcoma, we begin their breast cancer screening earlier, either at age 25 or 8 years after radiation. And then for colon cancer, if a patient were to have abdominal radiation for their sarcoma treatment, would start colon cancer screening at age 30 or 5 years after radiation, whichever is later. As I mentioned, genetic counseling is really important. We think that about 10% of patients with sarcomas have a primary tumor that arises at least in part due to a genetic predisposition. And so for example, with osteosarcoma, there's a small percentage of patients who have an underlying mutation in a gene called P53. That confers a bit of an increased risk to developing cancers like osteosarcoma, but also other cancers like breast cancer. We've learned that this can be passed down in some families, or some patients can just develop a new mutation in TP53 at the time they're a fetus, and really may have implications for how their cancer screening looks going forward. For all young patients, I really recommend that they consider genetic testing, or at least talk to a genetic counselor about what that might look like, given these numbers. So then for our patient, we would really move into more general late effect screening. The survivorship visit, whether or not this takes place in the oncology clinic or in the survivorship clinic, really should include a comprehensive review of the patient's treatment plan. Again, what was the chemotherapy? What was the surgery? Was radiation included? The review of systems, as we said, that kind of head to toe, how is everything feeling? Physical examination and any other radiologic exams needed. And then really a screening for the numerous long-term physical and psychosocial issues that may be relevant to patients with sarcomas. And so some of the ones that will be important in that survivorship visit, but we don't have time to go into in detail today, include bone health, lung health, if a patient were to have had radiation that involved the lungs, kidney disease as patients get older, is really an important thing to screen for. Many patients report things like brain fog or chemo brain after treatment, and we have good resources for that as well. And then the last thing that's not a physical symptom, but I think something that almost all patients grapple with after treatment, particularly young patients, is financial toxicity. And that may be loss of financial resources or loss of employment during treatment. This ends up becoming a huge challenge for many patients with sarcomas, given that they may have physical impairments after treatment and treatment-related fatigue that make it difficult to go back for work. And I think for our particular patient, that was really a challenge. We have multiple resources for this, but typically starting with social work is a good place to begin. On the right here, I'll just make note of the fact that we, of course, have a really great Dana-Farber adult survivorship program. And I think that's where this video will live in the end. But there's many great resources in those in that webpage for some of these issues. And then the final part is really striving for a healthy lifestyle in survivorship. There's somewhat limited data on the precise benefit of modifications to diet, physical activity, and body weight for cancer survivors. Those data, I think, are really very limited in sarcomas given the rarity of these diseases. But lifestyle modifications likely have a large benefit on numerous other long-term health issues associated with sarcoma treatment. So certainly is important for physical rehabilitation, for mental health, for bone health, and for cardiovascular health. All of which I've told you are often challenges for patients who are diagnosed and treated for sarcomas. We also have numerous resources on the Dana-Farber website for achieving healthy living during and after cancer. I encourage folks to check those out. So in summary, survivorship really begins at the time of diagnosis for patients with sarcomas. There are multiple issues that are key to discuss as you're formulating a treatment plan, including oncofertility, cardiac risk, and risk of second cancers. risk of long-term cancer and treatment-related health problems really vary widely by sarcoma type, by sort of extent of disease, and then the treatment plan that's required to address the sarcoma. Survivorship care occurs in multiple places, including the oncology clinic, the survivorship clinic, and the primary care clinic. And this sort of specific path towards transitioning to survivorship clinic or primary care clinic, I would say, is also very individualized and beyond the scope of today's talk, except that people do transition over time. And then I think, again, the good news and the reason why I was really excited for this session is that there is a growing body of resources to help patients live healthy lives during and after cancer treatment, or specifically sarcoma treatment. And so I really encourage folks to access those resources and talk with your care team about those resources. Thank you, and happy to take questions.
Right. Don't think there are any questions. So thank you again to the survivorship team and Dr. Shulman as well. You can find this on our Blum YouTube playlist, as well as our Blum Digital Resource Center and the survivorship website. So be sure to check all those out for some more resources. All right, have a great day.
Thank you.